So let's talk about double level osteotomies. When should you think about it and how should you do it? This is a slightly brief talk as it's a pretty straightforward thing in my opinion. So let's just dwell right into it. So once again, reiterating what Clement said, it's all in the planning. So the moment you see a patient with a severe deformity such as this, with the weight bearing axis flying to the contralateral side, that means the deformity is too severe and you will need something more than standard HTO. You of course measure the MPTA, you of course measure the LDFA and the joint line congruence angle, and you know the normal values of 85 to 90 and all that. So you need to correct the deformity at the same time, not cause a significant a significant obliquity in the joint line. An important message is not to correct the deformity in the wrong bone. We have spoken about this multiple times till now. We always think valgus needs a DFO and varus needs a HTO, but not always. And there are a lot of patients in which the deformity lies in the femur for a varus side and tibia for a valgus deformity. As you can see in this patient, it's the femoral deformity which is causing varus and not the tibial deformity. So doing an HTO in such a patient is going to be completely fruitless, and he or she is going to have a massive joint and obliquity. So planning is really important for deciding about where to correct the deformity as such. Now, the main problem of doing a massive correction or a correction in the wrong bone or too much of a correction in one bone is that you get a really badly oblique joint line. You know, the normal level of MPTA is 85 to 90 with an average of 87. Based on which surgeon you speak to, you will hear the acceptable level to be 93. When stretched 95, I would stick to the former. So I would say 93 as my cutoff point for acceptable level of MPTA. Now, it's a very good paper from Matthias Fost, who talks about if stringent criteria applied when they retrospectively looked at a good number of HTOs performed. Only 30% of varus knees are suitable for just HTOs and almost 60% need a double osteotomy. So if we are deciding just based purely on pre-op planning, then we are doing too less DFOs and too many HTOs for varus deformity, which is standard common practice for us. Interestingly, 8% of patients only needed DFO and not even required a HTO. So it's important to remember planning is essential before you start taking knife in your hand. The joint line obliquity more than 4 degrees usually indicates an inferior outcome. That means the patient gets progressive arthritis and he or she is going to need a TKR soon, within 5 to 7 years. But more than 6 degrees of obliquity has been proven to be quite significant, and more than 8 degrees is something disastrous based on Babis's paper that we all quote from 2000. A lot of new literature is available now which confirms that an oblique joint line is quite bad for the joint function. So this is a very good paper from Korea which talks about acceptable limit of joint and obliquity after HTO. So I recommend any of you who's interested to have a look at this one. There's one more brilliant paper again from eastern side Japan, which talks about the tibiofemoral stresses after high tibial osteotomy, but with varying MPTA. So this is slightly complex slide, but it just shows the weight bearing axis is exactly at the so-called Fujisawa point of 62.5%, but the MPTA has changed from 87 to 97. And what we find is that paradoxically, despite doing a massive correction, because of the joint line obliquity, the forces on the medial side again are found increase in extension as well as in flexion. So here overcorrection is detrimental despite shifting the weight bearing axis laterally, both in flexion and extension, and these patients get increased incidence of progressive arthritis both in medial and lateral compartment due to it. Okay, that's enough of theory. Now, when do you think of a double level osteotomy? So anytime your Mikulicz point is beyond 100 degrees in a valgus deformity or below negative 20 degrees, or sorry, 20% in a varus deformity. It's quite rare to do a double level osteotomy for significant valgus because most of the valgus deformities are amenable to correction with a DFO, but not for a varus deformity where you need a combined DFO and HTO if it's beyond negative 20%. That's my opinion. The literature states anywhere between 0 and negative 30%. Lot of syndromic deformities or post-traumatic deformities are very severe and they need correction both in femoral and tibial plane. And sometimes wrongly performed osteotomies can also be a candidate for a double osteotomy. Now, always think of a double osteotomy if your planned correction is more than 18 millimeters of an HTO. That means you are overcorrecting on the tibia and you're going to get a really awkward joint line angle. But I would suggest not to create a deformity to correct a non-existent deformity. So do not create a valgus deformity in the femur just to achieve a stable joint line. So I think you need to think of other options. I'll come to that in a few minutes. So someone like this, the planned correction is about 20 millimeters. So obviously that's a bit too much and you need to correct that properly. Always a common question is asked is which one first? It has to be always femoral first. Femur is a larger bone where the osteotomy correction that you can achieve is massively powerful. So always do femur first, and it's easy to dial the correction on the tibial side in HTO. So you can open by a millimeter more or less to sort of titrate the deformity to exactly the level you want. Now, there's a combination that you can do. You can have a closing wedge and a closing wedge, or an opening wedge and an opening wedge, or a combination of two closing wedge and an opening wedge. Now, it depends on what your comfort levels are and whether there is leg lengthening or leg shortening. Now, when you add two closing wedge osteotomies, you're going to have shortening of the lower limb. If you combine an opening wedge and opening wedge, you're going to get lengthening of the lower limb. But the best option is to combine a closing wedge on the femur and opening wedge on the tibia. This is normally for a varus deformity where you do a lateral closing wedge femoral osteotomy and a medial opening wedge tibial osteotomy. It works really well when you combine the two. Generally, leg length remains the same if you combine opening wedge and closing wedge in one go, but it changes depending on the patient status. So if someone has a leg shortening, then it's better to perform opening wedge and opening wedge as a combined procedure, which will give you a good amount of limb length increase, which is preferable for the patient. A few technical tips. As Clement said, good scanogram with calibration and patella centralized is very important for your planning. Now, always assess the deformity with an alignment rod on table before you start. I agree it's not as accurate as your software planning, but that's what you're relying on table. So if you do a pre-operative assessment, it's much easy to adjust the rotation to the same level during operation and post-operation to decide how much correction you achieved. I always start on the femoral side, depends on what you have planned. So do a pre-planned opening or closing wedge osteotomy. Once finished on the femoral side, assess the deformity again. Now, you will realize that almost 60-70% of the deformity is already sorted by your femoral correction. And then you can do the tibial correction to the desired point. And the important thing is you can use the graft from the femoral side to graft on the tibial side. So you have a ready-made bone graft available for your tibial side as well. A couple of examples. So Asha is a 52-year-old lady who had significant varus deformity of both of her knees. You can see it's quite severe. Now, this is the preoperative planning. This is a TraumaCAD planning software, which I really like. And you can see the angles there. So you can see the deformity where it exists, both in femur as well as in tibia. So the MPTA is 83 and LDFA is 95. So both need correction. And this is the planned correction, 7.3 millimeter, or let's say 7.5 millimeter lateral opening wedge osteotomy, lateral closing wedge distal femoral osteotomy. And to compensate on the tibial side, we'll do an 8 millimeter opening wedge tibial osteotomy. Now, other side also is similar. So you can see exactly a similar pattern on the other side is 8.7 millimeter distal femoral osteotomy and 7.7 millimeter proximal tibial osteotomy. So this is an important way of planning it properly. If you look at my MPTI is 94. So I'm breaking my own rule here. I did correct it slightly less to go into 93 or so. So the procedure is pretty straightforward. Start on the femur, do a lateral closing wedge distal femoral osteotomy, take the bone piece off, as you can see here. Now, once you have done this, you can easily close the osteotomy without breaking the hinge. Once that happens, you fix the osteotomy on with a good robust plate on the lateral side, on the femoral side. Then you use the same bone graft that you took off on the tibial side and correct it on the tibial side. So it's a pretty straightforward operation if you follow the steps carefully, and it just adds about 40-45 minutes to the main surgeries in terms of total. So this is the post-operative X-ray, and you can see the deformity is pretty well corrected, and the leg looks perfectly well aligned following this. So that's the scanogram post-operatively, and she's pretty happy with this one. So I did the other side as well, and then she refused to have another scanogram, saying she doesn't need any more X-ray. She's quite happy with the whole correction as such. So you can achieve a brilliant correction by doing a double level osteotomy on both legs and get perfectly straight legs on both sides. And this is about 5 years down the line now, and she's doing quite well when I last spoke to her. Another patient, 53-year-old female, something similar, quite a sort of active lady into politics, an MP of one of the parts of Mumbai. Now you can see a pretty severe deformity in both of the legs. Now I spoke to her, discussed in details about the planning, and she refused to have a femoral osteotomy on the left side. She was hell-bent on just having HTO. So I just did HTO with about 16 millimeter of correction. I got my MPTA to, so I've got my joint, sorry, MPTA about 93 and stopped there. So I'm slightly undercorrected on the left side, I agree. On the right side, the deformity was severe, and I planned it for a good 6 millimeter femoral osteotomy and a 10 millimeter HTO. Now, those of you who are watching keenly can see I've planned for a medial osteotomy, both femur and tibia, because this leg was quite short. So we did a medial opening wedge DFO and a medial opening wedge HTO, both at the same time, and the leg length is almost normal now. She's longer by about 3 millimeters on the right side. The left side plate has been removed, and if you can see, the alignment is pretty good. Left side, I agree, I've slightly undercorrected, but she's not symptomatic anymore, and she's gone back to a normal life, doing all her activities without any issues as such. Of course, you can make the matters much more complicated. You can combine a TCVO, HTO along with a DFO to correct very severe deformities. Thankfully, this is not one of my patients. That takes a lot of guts to do these two together. This is from one of the papers that I found, but this is indeed an excellent option of correcting the deformity the way we want to. A couple of references that I took some of the images from and references details from, and these are very good papers to go into, and that will hopefully help you in correcting the deformity properly. Now, just a quick, so I've started using Bone Ninja software now. Can you see my screen?
Not yet, Bhushan. So it seems to have frozen, at least at my end.
Okay, give me 1 second. Let me share that again. Can you see that?
Yeah, it's very clear now.
It's something I'm planning now. So you can see the severe deformity. This is just an example. I just did it 5 minutes back. So I'll just show you what I'm planning to do. So I'm planning to do a lateral opening wedge distal femoral osteotomy to get the deformity corrected slightly. So it's not going to be perfect. So I'll add a medial closing wedge HTO to that, and hopefully I'll get a relatively perfect correction by doing this. So that's my plan for this lady, and I should get a perfectly straight line. So in Bone Ninja, once you're done a first cut, unfortunately it doesn't show a perfect line. So you need to get the ankle level where you want to, and then decide how much correction you're going to do. So this is generally the way you plan a distal femoral osteotomy along with a high tibial osteotomy for complex deformity correction. You can also play with the slope. You can also do a derotation osteotomy along with that. So it's actually sky's the limit about how much correction, how many things you want to correct. It just needs proper planning and proper execution.